if you open up the chat bubble, which is the little speech bubble at the top of your Teams screen, you'll find the link in the chat to Menti, and we'll be using that a little bit later on in the presentation. So you can engage with us, tell us what you think, but also tell us how you can work with us as we move forward with this community profile. So I'm delighted to welcome you to the presentation today on the Muslim Community Health Profile. I'm Dr. Justin Varney, I'm the Director of Public Health for Birmingham City Council. I'm going to do a little bit of housekeeping to start off with, and then I'll be handing over to Councillor Mariam Khan to give the welcome and opening comments for today's presentation. If I can ask everyone to mute yourself during the webinar, and unless you're speaking, please keep your camera off, because it just helps people who've got lower bandwidth, which I think just helps all of us. If you want to ask a question, you raise a point, please use the chat function, which is that little speech bubble at the top. And we are recording the webinar today, which means we can put it up on the Healthy Brum YouTube channel afterwards, so others can see it and learn from the discussion as well. We move on to the next slide, please, Jordan. So we'll be using Mentimeter, as I said. If you're working on a laptop, you've got a phone, a smartphone with you, it's often helpful to open it up on the phone so you can answer the questions and still see the screen at the same time. You can open the camera on your phone and take a picture of that, or move it to take a picture of that black box, and that should open a little thing that says, do you want to follow this link? That will take you directly there as well. And I hope you can participate with us on the Menti, because it is a good way of us being able to capture your thoughts and views as we go through the presentation, and we'll be doing a segment at the end, particularly around it. But without further ado, I'd like to invite Councillor Mariam Khan to say a few words to open today's session. So hand over to you, Councillor Khan.
Thank you, Justin, and good morning, everybody. Sorry, excuse me. That's a wonderful start, isn't it? So, hi everyone, my name is Councillor Mariam Khan. I'm the Cabinet Member for Health and Social Care at Birmingham City Council, and I'm delighted to see the launch of so many of our community health profiles, and so extra pleased to be welcoming you all today to the launch of the Muslim Community Health Profile. As a Brummie Muslim, I'm proud of how diverse Birmingham is and of how welcoming we are to people who choose to make the city their home. However, we do know that not all of us experience the same levels of good health and well-being as each other, and that there are real differences in communities. In the council, we take this seriously, and we see that tackling these unfair differences in health as a core component of the work that we do. The community health profiles have been identified and summarised the physical health, the mental health, lifestyle, behavioural and wider determinants of health-related issues affecting communities both locally and nationally. And the findings from these key public health documents will shape how we address, protect and prevent health inequalities in our city. We've always struggled with understanding the detail of some of these inequalities, and this is where our community health profiles come in. The Public Health Communities team have, in partnership, developed a series of evidence summaries that focus on helping improve our collective understanding of our diverse communities, the health and well-being challenges and key inequalities that they face. I really hope that you find this session useful. We've got the opportunity today to share our approach and findings with you, and afterwards we will look to work together, not only for our respective communities that we're talking about here, obviously it's the Muslim community, but for Birmingham as a whole. So I'm really delighted to be here and be able to discuss and take part in the discussions that will happen later on through what Justin has said in terms of the Menti option. But it's been wonderful so far to be part of some of the other community health profiles, and I'm hoping that everyone here today will see the benefits of us being able to launch these and have these as a toolkit for not just us and the people within the public health division, but for the wider Birmingham community. I've been talking about these community health profiles in meetings and sessions that I've been having with people both internally and externally, key stakeholders and partners across Birmingham, and they're all quite excited to be able to get their hands on something that has been developed here within the public health team, and something that they can use in the work that they're already carrying out, or that they will carry out across the city. So without further ado, I'll hand back to Justin so that we can start the presentation. Thank you.
Great. Thank you very much, Councillor Khan. And I think, as you say, it's a really important point that the community health profiles are being used not just by the council but by a lot of our partners to deepen our understanding of specific communities and go beyond just the headline of people that hold religion and actually delve into some of the differences between religious communities and the inequalities that affect them. And in the same way, we'll be going beyond that headline of BAME and delving into different ethnic communities, similarly for LGBT+. So it's really exciting, the work that the team's done to pull together these community profiles, and I'm really pleased we're able to share them with you today. So just to start off and give you a bit of context about the community health profiles before we delve into the detail of the Muslim profile itself. So public health in the council is required to produce 2 evidence reports. One is the joint strategic needs assessment. That's an annual or biannual snapshot of the health and well-being of the city. And every local authority in the country has to produce a joint strategic needs assessment at some stage. It doesn't have to be every year, and increasingly we're moving that to every few years because there's so much of it's reliant on the census data, and that doesn't change year to year. The second is the annual Director of Public Health report. That's an independent report of the Director of Public Health and their team, and it tends to be very topic-based and focused. So those are the 2 things the council has to do in terms of looking at population health needs and the evidence around that. We choose in Birmingham to go beyond that. And there are 3 types of report that we produce based on evidence. The first is where we do a deep dive. That's like a mini JSNA, a mini joint strategic needs assessment, where we're looking at a specific community. Takes about 18 months to 2 years. It's quite a long piece of work. We do that involving focus groups as well as looking at the published evidence. So it's a mixture of kind of research evidence and lived experience, and it is quite a large piece. And we aim to do about 2 to 3 of those a year on different topics, and the topics are chosen by our Health and Wellbeing Board. The second model we have, which is also quite a long-term model, is topic-based commissions. And these are 2 to 3 year projects where we work with citizens with lived experience, and we really focus on solution focus. So we're not just looking at the problem, we're now really looking at the evidence base around the solutions and the interventions. And there are 2 topic-based commissions we've been running, or thematic commissions. One is the Birmingham Lewisham African and Caribbean Health Inequalities Review, Blackie Review, which ran over 2 years, and we're now in the implementation phase of that. And the second is the Birmingham Poverty Truth Commission, working with people with lived experience of extreme poverty in our city and helping them sit around the table with policymakers and politicians to co-create solutions in our city. So that's the second model. The commissions run for about 2 to 3 years, and again, very in-depth pieces of work. The third model is the community health profiles, and we'll be presenting the Muslim community health profile today. These are desktop programs where we look at the published evidence as well as some of the grey literature. So that's stuff that's like reports from charities would fall into a grey literature space. It's things that not in the academic journals, the academic publications. We also look at population data where we've got it. And it's really a snapshot of inequalities within communities. The difference between the community health profile and the other 2 is that we don't do this in a co-production way. It's very much looking at what does the data say. And then there's a second phase of the community health profiles where we commission a community partner to work with us and the local community on the so what. How do we want to respond to this evidence? Where do we want to put some effort? And there's some pump priming resource to support that engagement in terms of taking action. So that just gives you a context to the community health profiles and how they sit alongside other data reports that we do. So the community health profiles align with our ambition as a city to create a bolder, healthier city in which everyone at every stage of life can enjoy a healthier, longer and enjoyable life. And they help us understand the gaps in health in specific communities, and they're designed to focus in quite narrow communities in terms of very specific communities, rather than taking a kind of overarching umbrella approach to the difference. They're designed to help us both in terms of the council and our partners like the NHS understand these communities better, but they're also designed to be giving the communities the information to help them as they advocate for the support they need, but also celebrate some of the assets and some of the positive findings as well, because often it's really easy to get focused on the negative side of things because that drives funding, it drives resource, but actually also is an opportunity to focus some of the positive differences affecting communities as well. And we aim to refresh them every 5 to 8 years, again, because they tend to draw quite heavily on census data. Census only happens every 10 years, but they're also based on research data, and research doesn't change that quickly in these spaces. So that's the kind of timeline for the updates of them. So in terms of the forward plan and where we are and what we're doing, I've talked about the commissions, obviously. Deep dives, we've published the first 2. They were a little delayed in our plans because of COVID, as you'd understand, but they're in train at the moment on learning disabilities, dual diagnosis, mobility impairment, sensory impairment, and those will be out over the next 6 to 10 months. And then the community health profiles. And as you can see, there's quite a long list of these. And part of the commitment we made through the Commonwealth Games was to accelerate some of the community profiles around ethnic communities from Commonwealth heritage. So that's why the list is longer for the community health profiles. And we're talking today about the Muslim profile, which is live on the website as well. So you can access it after this webinar as well. So they aim to help us understand the evidence base around the community better. We do that in a structured way, linked to the 10 priority areas identified through the overall strategy for improving the health and well-being of Birmingham citizens, creating a bolder, healthier city. And the opportunity then is to use the community health profiles to engage with local communities through that engagement partner and start to work on the so what. How are we going to change this moving forward? Some of the community profiles, people have read them and go, this really resonates. I recognise these gaps, these inequalities, but we need to change things. And that's why we've got the second part, which is the commissioning of the partner to take forward and try and change some of these things for the future, because many of the inequalities, many of the gaps we've identified have been there for a long time. There's also an element of this which is about improving the skills and knowledge of our own staff and those across the public sector and in the voluntary and community sector in understanding the inequalities better. And we're already seeing from the first profiles that have been published, people have really seized them and gone, actually, I do want to understand our community better. And these are really helpful starting point to increase my knowledge and my understanding. The themes that we set out in the Bolder, Healthier City strategy are in this slide, and you'll see that the community health profiles are all structured following this, and this pretty covers the breadth of public health, but it also includes some of the things that drive health, how our city is designed, how people interact it, the food that they eat, the jobs that they have, their educational attainment. So it's a pretty broad capture of the evidence base, but we are reliant on what's there, and you know, the important bit of the community health profiles is they're based on evidence, data and research, not on anecdote, and in many cases in the community health profiles the research just isn't there, and particularly for religious communities, actually one of the great kind of findings across these profiles, or things that it's reinforced, is how little research and how little we analyze data based on religion. You know, and that makes it really challenging to understand the differences between different religious communities. And that's not just true for religion, the same is true for disability and for sexual orientation. So I'm going to invite Priya to talk to the next couple of slides. Some of the community health profiles we do in-house, some of them we commission out, and I was delighted that we were able to commission the Bayswater Institute to take the lead on the Muslim profile. So Priya is just going to talk a little bit about the methodology that was used to develop this profile. So Priya, can I invite you to come on camera and just talk a little bit about how you did this and how it was created?
Thanks very much, Justin. Hi, everyone. It's lovely to be here and tell you a little bit about the methodology that we use to collate the evidence for the Muslim community health profile. So we undertook a comprehensive review of academic and grey literature sources, as Justin's touched on. The academic citation and literature databases that we used are outlined on the screen here. And some of and the search terms that we used to put to search these databases, we documented them in the appendices in the main report. The grey literature that we use mainly came from voluntary community sector organisations, but also from the Office of National Statistics, the NHS, Public Health England, and Muslim-specific organisations such as the Muslim Council of Britain. Only studies which focused on Birmingham, really that was the focus of our search, but studies which focused on Birmingham, but also studies which related to the wider context in England, Wales and the UK were included, and only studies post-2000 were included. Only studies with a minimum of 10 Muslim participants in qualitative studies, which tend to have smaller samples, and 10% of Muslim participants in quantitative studies were included. And in order to contextualize the evidence base around the Muslim community, we use comparator groups. So here we use the dominant religion of Christianity, other dominant South Asian religions, Hinduism and Sikhism, and also people with no religion. Now, as Justin mentioned, particularly when it comes to evidence on religious communities, either in the sample that researchers tend to collect or in their reporting, it can be sometimes difficult really to pick out data specifically relating to the Muslim community. So there are several limitations to be aware of in terms of the evidence base that we drew on. So for example, the population data that we extracted from the 2011 census should be read with some caution, given that it's likely to have changed over the last decade, and the 2021 census will provide us with more up-to-date information. A common drawback of existing studies, and this is both quantitative and qualitative studies, is that authors tend to fail to recognise the diverse ways of defining difference and the multiplicity of hybrid identities that are associated with the socially constructed category of Muslim, and also of British Muslim, of British South Asian Muslim. Other limitations in relation to the methodology of studies, and some studies, again, both quantitative and qualitative, is the tendency of authors to conflate ethnicity with religion. So here for mainly sort of Bangladeshi and Pakistani with Muslim. And often they would use ethnicity as a proxy for Muslim, or rather ethnicity as a proxy for religion, without real consideration or contextualization. Now, in this report, where a lack of data on the Muslim community has meant that lack of data on the Muslim community has meant that we had to rely on ethnicity as a proxy. And here we mainly use Pakistani and Bangladeshi communities. Here we highlighted this throughout the report whenever we use such a proxy. And the studies which we included in this context were only studies where authors explicitly referenced their sample of participants as Muslim, even though they might otherwise elsewhere in the report have drawn on ethnicity. So that's really just to give you an overview of the methods that we use to collect the data and some of the limitations of the data which should be borne in mind when reading the report. Thank you.
Great. Thank you, Priya.
Thank you, Justin.
So we put the link in the chat. We'll also reshare at the end around where you can access the profile itself. Alongside the profile document, we also do YouTube videos of the highlights. We're running webinars like this. And what we've also committed to is translating the resources into at least one language if it's appropriate to the community. So if the community that we're focusing on has a predominant first language that's not English, then we are also translating the community health profiles as well to increase access. So that's given you a bit of context and background. Now going to talk about some of the things that we found through the Muslim Community Health Profile. And this is going to be a bit of a whistle-stop tour. So I'm going to move quite quickly, but it gives you a bit of a flavour of what's in the document. And I hope excites you to spend some time reading the document and delving in more detail. So first of all, a bit of an overview of the community. Islam is one of the largest religions in the world, and it's one of the fastest growing religions in the world. And looking at the estimate populations in Birmingham, Muslims make up about 27% of our population, so a much larger proportion of the population who have religion in Birmingham believe in the Muslim faith compared to the national average. And I don't think that's a huge surprise for any of us that live in the city. You know, Birmingham was one of the first cities in the UK to have a mosque. And I think our oldest mosque dates back to the 1930s, founded by our Somali Muslim community. So there's a long history of this. So if we move on to the next slide. Kind of headlines that came out of the community profile, evidence of barriers to accessing healthcare, particularly around accessing mental health services and poorer treatment. Low engagement in sport and physical activity was something that stood out. Lower rates of full-time employment. And a lack of data in a lot of areas. And I can see in the chat some questions around the census data. One of the challenges for us around religion is that we're very reliant on census data. It's not routinely collected in a lot of services, both in NHS and in local government. And you know, one of the things I hope that comes out of the community profiles is that all partners start to look at the data they're collecting and get better at it. Because if we were routinely collecting data on religion, for example, in our hospital data, we would be able to analyse and look at, for example, the admissions for heart attacks by religion. But because we're not collecting it routinely, and therefore we're not able to analyse it because it's not there in the majority of data, we're stuck, and that's one of the challenges. So it's important we think about that around kind of some of what we're finding and what does it mean in terms of moving forward. A large proportion of the Muslim population in Birmingham are children, and what's I think one of the most stark findings is that 46% of Muslim children in the last census lived in the 10% most deprived parts of England. And that pattern, I think, does carry through in terms of the Birmingham picture as well, although not quite as strongly as it does nationally. Muslim children in Birmingham had lower attainment at school. And that's an interesting challenge when you talk about also that headline around the population and how many of them are in full-time employment being a challenge. There was some evidence relating to maternity, and what we find in many of the community profiles is that if there's been a particular research or a research initiative around a particular topic like maternity, we've got quite a lot of evidence in that space. But that might not be the same, for example, around falls in older people or social care. So you do find in the profile sometimes there's a lot of evidence in one space, and that's because there's been a particular research initiative, and maternity is one of those examples. And we do see evidence of higher infant mortality in Muslim communities, barriers accessing maternity services, and raising an issue which we've seen in some of our work with ethnic communities as well, that there is a need for the NHS particularly, but other partners working with pregnant women and their partners to develop a much better culturally competent, culturally intelligent approach to care. So if we move on now to think about mental health and well-being, there's research showing that in older middle-aged Muslims, higher rates of reporting being unhappy or depressed, lower uptake of services, and some of the research that's explored that has highlighted stigma within the community, within the faith community around being open about mental health, talking about lack of awareness of what's available and the services that are there and not necessarily responding. And that overlap between religious discrimination and racial discrimination. And one of the challenges in the research is actually trying to unpick that and where people are to some extent using those as overlapping and interchangeable discriminations, which makes it a bit more complex to understand. What I do want to just add, though, in this one particularly is, as we've gone through this journey, we haven't always just kind of gone, oh, yes, that's a problem, let's ignore it. Particularly in the mental health service space, I'm delighted that we have commissioned work from Delicate Mind as a programme which has been running for over a year now, specifically working on mental health support for our local Muslim community and working with the mosques of the city and the masjids to support particularly men from the Muslim community accessing mental health support, and we are continuing that work. There's also been specific support to provide mental health first aid training to our faith communities, and the Muslim communities being part of that as well. So these are things where we have started to take action already on some areas. We're not just waiting for the profile to be published. I thought what was really interesting actually though in this one is to flag that data around smoking. 18.4% of Muslim men are smokers. That's higher than the average for Birmingham, quite a lot higher. And some of that will be smoking cigarettes, some of it will be smoking shisha. Both bad for your health, both associated with lung cancer, etc. So it's some important data there, and I do encourage you to have a read of the report where we're able to look at intersectional difference. So we're able to look, for example, as differences in mental health in Muslim women compared to Muslim men. Depends on the research and it depends on the size of the sample. And as Priya said, much of the research is quite small. And many research studies kind of look at religion as a bit of an afterthought, and that's a real challenge for us. So if we move on to just touch briefly on food, example of this is we don't collect obesity data by religion. So obesity data is both captured by the NHS, by our GPs, and it's also captured for children through the National Child Measurement Programme. And we don't capture religion in that data set, so we're not able to do the analysis. So we have used in the report a proxy in terms of talking about what we know from ethnicity in communities where Muslim faith is very represented, but it's not a direct read across. There are a small number of studies that specifically looked at obesity and at dietary behaviours, and they do raise some concerns and some risks, but it is an issue that there's a real lack of evidence in this space. Moving on to physical activity, that's in the kind of contrast, the national survey that's done on physical activity active lives, which is a rolling survey, does capture religion and faith. And so we are able to look at that, and that shows that Muslims nationally are more inactive. So that means when we talk about inactivity, people doing less than 30 minutes of physical activity a week. So that's really, really sedentary lives. And what we know for physical activity is that being active every day makes a huge impact on your health. So 10 minutes brisk walk every day is as effective as Prozac in treating mild to moderate depression. 10-minute walk a day. Yet too many of our Muslim community are not active, and the risk reduction plays out for diabetes. Within 2 months of being physically active every day, you can reduce your blood pressure. So those of you who've had your blood pressure checked recently, and I'd encourage everyone who is at least middle age or above, please go and do check it, because knowing your numbers really makes a difference. It's 2 numbers over a line, and that's a measure of blood pressure. We know we can reduce that by 10 within 2 to 3 months of people being physically active every day. So some really important opportunities there. And the campaign we've been running with Tola Time to promote opportunities, and Native put in the chat, so Healy Hub's a good example of a local community organisation specifically engaging with our Muslim community promoting physical activity. The Active Wellbeing Society across the city, but particularly in East Birmingham, have a range of programmes that have been supporting, and one that comes to mind particularly is the work around supporting Muslim women to get into badminton, which not necessarily something that comes immediately to mind, but actually was something that the women asked for, safe opportunities. So there are opportunities out there, and also our leisure providers have really worked on how can they improve and support the engagement of all women in physical activity through our leisure and wellbeing services. But it is a space where, you know, if we can increase awareness in the community, as well as improving the opportunity of services, we can make a real difference to people's lives. Moving on to working well and learning well, one of the things that the report reiterates, which I know for many of you from the community will kind of go, yeah, we know that, is that the proportion of Muslim households which are multi-generational. And you know, we know that in Birmingham, it's one of the things we responded to, particularly in the COVID vaccine programme, working with the local NHS to offer intergenerational vaccination, so offering to vaccinate everyone in the house at the same time rather than waiting for the age cohort to come along, because we know in some households that was a real discussion, that everyone was saying, well, we're going to vaccinate as a family, not kind of do it one at a time, because that's the way that we function as a family, we do things together. And I'm really grateful for the local GPs who championed that and made that happen, because it was a real step forward and it had an influence nationally. I'm also very grateful to our local masjids that stepped up to provide vaccination hubs. And again, Birmingham led the way nationally on working with our faith community, particularly our Muslim community, to increase access. So we are aware of that, but there are still long ways to go and there are some still challenges. So if we look at employment, the patterns of employment, there are some differences, high rates of unemployment in our Muslim community. So I think there is still some significant steps to go forward. And some of that's around how we work with employers to make sure that we're creating faith inclusive employment and thinking around how do we support access to prayer rooms, prayer spaces, increasing awareness of faith and religion in organisations, and also supporting our chaplaincy movement. We use the term chaplaincy, but actually encompasses all faiths. And you know, one of the things that I think I've been really pleased about over the last couple of years is the relationship we've built between public health and the West Midlands chaplaincy network, and supporting them around what they do in workplaces to support people of Muslim faith alongside other faiths. So moving on to protect and detect, this is one of the chapters of the strategy, and it talks about how we protect people from infectious disease, but also how we detect earlier disease. And you know, there are some quite concerning things in terms of the data that we were able to find. Muslim women, 51% are less likely to attend breast screening than Hindu or Sikh women. And I think that's a really important thing to flag. Breast screening for breast cancer is a really important way of ensuring that people that have disease, we catch it early. And the earlier we can identify cancer, the better the treatment outcome. And this is often because by the time you can feel a breast lump, the breast cancer has already spread. So by having the breast cancer screening, by doing the mammography, you know, it is uncomfortable. It's not, you know, it's not a great experience to have to go through for women. And we work every day to try and make that more comfortable, more respectful and more dignified. But it is an incredibly important way of finding breast cancer when it's too small to be felt. And if we can do it at that stage, we've got a much better outcome for women in terms of treatment, and the treatment itself is much less invasive and much less uncomfortable. The same is true for bowel cancer screening. You know, the uptake is lower, so we've clearly got to do work with NHS colleagues who lead on the cancer screening programs to increase uptake. In terms of COVID, we've worked really well with the masjids of the city, but there are still challenges. And looking at the national data, Muslims were much less likely to be vaccinated against COVID than other religions. But I am really grateful. I do want to give a shout out to the masjids of the city, because I've been meeting with them really regularly. It was weekly in the first wave of the pandemic, and they really stepped up to help us through in terms of communicating and engaging with the community, which is really important. So if we move on to aging and dying well, this highlights one of the differences, I think, in terms of where we've looked at Muslim population versus the general population. And if you look in the report, where we're able to provide comparators with other Asian categories or the general white population, we're doing both. So the report has much more detail than these slides. But as you can see, higher rates of self-reported bad health in both Muslim men and Muslim women. Older Muslim patients may have access issues because of language, and that's that overlap of ethnicity and religion. But there are some really interesting things that come out around use of end-of-life care support, particularly use of hospices, use of care homes, use of social care. And I'd say this is not unique to the Muslim community. We found it in some of the other community profiles, that there is some work we need to do around social care, and particularly around end of life, is helping the community understand the offer while making sure that the offer is culturally appropriate, so that families are confident that if a relative does go into one of our care homes, does go into a hospice at end of life, that the food is halal, that there will be opportunities to access prayer and access teachings remotely if it's not possible physically, and that we've, as a system, we've thought about that. Because I think that comes through quite strongly as a message. There are some specific communities, specific health issues in aging, where there is evidence of increased risk in the Muslim community, particularly around diabetes, heart disease, and high blood pressure. And that reiterates why we need to work with the community more around smoking and physical inactivity and diet, because there are all things that we can do every day that reduce our risks of having a heart attack, a stroke, or high blood pressure. And then finally, we talk a bit about closing the gaps. And one of the big challenges around closing the gaps and understanding the differences within the Muslim community is that the research samples are so small that when you try and kind of break that up and separate that out, it just isn't there. You can't cut the data. You get down to too small numbers for it to be meaningful. And there is very, very little evidence, if any, that looks at the difference between the health of Sunni and Shia Muslims. And this highlights one of the things that you will see through the report is we recognise that the Muslim faith is not one homogenous blob, that there are differences in faith, there are differences in interpretation by the scholars. And I think actually in Birmingham, we are really in that space of having those conversations with the masjids, and we have done particularly through the COVID pandemic, talked to multiple scholars, got multiple views of scholars, so that we can reach a consensus across the diversity of the Muslim faith, because I think that is a really important thing to recognise as we have this conversation around the Muslim community. So just moving forward, we're going to give you the preview of the infographics. I do want to say the version that is online at the moment is not fully accessible for people with disabilities in terms of the electronic readers. We've had some issues with the design PDF in terms of how accessible it is on the infographics section. So the version that's online is not fully accessible yet, but we're working to a timeline that will be fully accessible by Christmas. So apologies for colleagues who use particular reader adaptions. This PDF does have some glitches in it, particularly around the infographics. So I just want to make people aware of that, but we are working to fix it. So in the infographics, you get a bit of a summary of the sections of the report, talking around the context of the population, pulls out a little bit of the cultural context, and some of the key statistics. And we just flip through these. I'm not going to talk through them in detail, but it's really just making you aware of the infographics, and the infographics are designed to be kind of, if you haven't got time to read the whole document, flip through the infographics, and that might also trigger you to go, actually, let me go and look in a bit more detail around these and around a particular bit of the report. And you can see that the structure in the infographics reflects the structure of the report. So I'm going to stop talking about the report there. I really encourage people to have a look at it and have a read about it. But now we're going to move into the Menti bit, which is getting a bit of from you about your reaction, your thoughts, etc. So if I can ask everyone to go on to the Menti. And there are a couple of questions just to get us started to understand a bit about you. And Jordan's just going to flip so we can see these live. So if you've logged into the Menti, and we'll move to the first question. So that's a bit of a slider. So on your phone, or if you're accessing it on the laptop, we just want to start off with a bit of a fun question. How are you feeling at the moment? How do you feel? And it's got a range of words as you move the slider across, but just flip through that. And I should say, Salma asked a question in the chat about the infographics. Where we've got Birmingham data, they're on the infographic. So the majority of the information, if we've got it in Birmingham, it's on the infographic already. The infographics are designed to be primarily about Birmingham, it's only where we can't get Birmingham data because of what's available that it's presented as national, or if it's a comparison. So for the population data, for example, in the infographic, it goes from international, national picture, Birmingham picture. So if we could find it, it was there. So brilliant. I can see 16 of us have managed to get on. You'll see the little person in the bottom corner of the screen, that little person with the number above their head tells me how many people have done the Menti, which is a good way of tracking how engaged people still are, or if you've gone to make a cup of tea while this is on in the background. So if we move on to the next question and keep moving through, this is around your demographics. So we're just asking who's in the room, and this gives us a sense of who's participating today. First question is, what is your age? So you can just flip through these and just select your age and submit. And then you can move forward through these at your own pace. The next question asks you, how would you define your ethnicity? And the reason we're using this as a rather than a kind of checklist that we have used in the past, is that some of the work that we've been doing with our ethnic communities have said that checklist approach doesn't help. Particularly, for example, from our Kashmiri community, feel that their identity isn't acknowledged. So how you define your ethnicity, and we're using this, and it creates at the end, when we will be able to present this, a kind of word cloud format, and it just is a slightly different way of capturing ethnicity from the normal tick box you might have seen before. You can move on from that to then help us understand your religious background. Again, that just gives us a sense of who's in the room today. And also, when we're analysing the questions, although we can't cross-reference who said what, it does give us a sense. So if, for example, we're talking about the Muslim community profile, and it's great to see the majority of participants are from the Muslim faith. But if, for example, everyone in the room was Jewish, answering questions about the Muslim profile, we'd look at those answers in a slightly different way. The next question, if you move forward, is asking, do you consider yourself to have a disability? And then the final question on the demographics is, what is the first part of your postcode? So that's the kind of B1, B21, B29 bit. And that's to help also get a sense of, are the majority of people in the room from Birmingham, from those wider West Midlands, or across the country? So you just pop in, but we're not putting those up on the screen, so you don't get to play hunt the postcode. So that's the bits for this, the results are hidden. So now we've got through all of that, let's get into the really important bit of the Menti. So the next question is, how can you help us get this information out there, and particularly into the communities that we want to reach, into the Muslim community? Because the community profiles are kind of layered in two ways. one, we want to make sure this gets to people working with the Muslim community, but as importantly, we want to get it into the hands of Muslims in Birmingham and across the country and allow them to use that as something to say, look, these are our health inequalities, these are the issues, and use that to work with public and private sector and community sector partners. But also, this sits alongside our community faith toolkits, which have also recently been published, and there'll be a webinar, I think, later this year on the faith toolkit. And we have one that we specifically co-produced with the Bahu Trust on creating a healthy faith community in the context of the Muslim faith in the masjids. So these will sit, the Muslim community health profile and the Muslim faith setting toolkit sit really well together for our engagement partner taking this forward. So I can see some brilliant comments and responses to this one. So if you move on to the next question, this one's really thinking about in your role, in your day job, and whatever that day job is may be, how might this have an impact? And it may be just in your personal interactions with any service users. It may be that you're not quite sure at the moment, and that's fine. Or there may be something very specific because you look at it and you go, actually, what I need to make sure is myself and my team have all read this, and then we'll have a bit of a discussion in one of the team meetings of the so what. So what does it mean to us? So again, any thoughts on that one? And you can also send additional comments if you want to through the Menti as well later on. But that one may be one that you kind of take away and have a bit of think about. For those of you that are moving forward through the Menti, the next one asks you to do a bit of prioritization. So the things at the beginning, which we said were really important in terms of they came out with the strongest evidence. That doesn't mean they're more or less important for the community, but the ones where we can see really strong evidence, there's a decent amount of research that's been done, and therefore we can use that to influence policy. How would you prioritize them in terms of the low engagement in physical activity, the lack of data and evidence, the poor outcomes in mental health, the barriers in accessing healthcare, or the issues around employment, and particularly that balance between part-time and full-time employment. And this just gives us a bit of a sense of kind of what's in the room, what do people think around this, and you know, how they engage. I think really interesting point from Alex around can we pick this up with the chamber and think around businesses, and that's a really important thing to think around how dissemination. So how can larger organizations in the city build this into the work that they do with contracted businesses, so the businesses that work for them, they have contracts with, and tie it into a bit of the social values, for example. So how and run this kind of seminar with your contractors, for example. And that's certainly something I think it's a good point, Alex, and I'll have a conversation with the Chamber of Commerce about how we might work with them on this as well, because I think it's a really good opportunity. So yeah, do you put your views, your votes in? Because one of the things is this is a kind of voting metrics, and where we've used this model before, this kind of Menti voting, it's been really interesting because many of us have got quite strong views about what should be in what order, but when you do it like this and it's kind of quite democratic, sometimes some of the things you feel really strongly about get pushed down the list. But that's the nature of making more shared decisions and involving people in understanding. And I'm really pleased that we've got Salma Yaqub from the NHS Integrated Care System on the call today with us, who leads on the inequalities programme there. And I know Salma will be definitely taking on board and taking forward some of the reports finding that relate particularly to the NHS, because I think this builds on the existing partnership work we have with the NHS in this space. So then if we move on to the what I think is the final, possibly penultimate or final question of the Menti is, what should the future of engagement for the profile look like? So as I've said, we are commissioning engagement partners to work with us around the profiles and to work with the local Muslim community in the case of this one. For the faith profiles, that's in partnership with also embedding and continuing to develop the faith setting toolkits. But any thoughts around how we could do that? Any ideas, any particular partner organizations you want to flag? And do put that in the chat box, sorry, in the chat box, or put it in the Menti as well, which I think would be really helpful. And then if we move on to the final one of the kind of text-based questions, and do take your time on the previous one, you can always catch up if you want on this, is how should we measure success? What does good look like? Yeah, and from your perspective, when we come back in 5 years to refresh the profile, what will have changed? How would you measure that in essence? Okay, so we can see some answers coming through, which is brilliant. Because I think one of the key bits of this is we don't write reports in public health to just stick them on the shelf. We want them to make a difference. And part of asking this question is we've got some thoughts about what would be different, but asking you and getting your feedback is really, really helpful. So do give us your thoughts on that one. And then if we move on to what I think is the final, yes, it is the final slide. Having gone through all of that and having thought about it, where do you feel now in terms of your feeling at the end of this and the end of having your presentations today? So it looks like most people are ending the session much more at the right end, at the energized end, than they were a bit earlier on, which is really brilliant. So that's the end of the Menti session. I want to invite Councillor Khan, if she's willing to just say a few words to close the session. Really grateful for your time. When we talk about the next steps of the programme, we are commissioning the engagement partners to take this forward and make a difference and really work with the communities on the so what. Just before Councillor Khan comes in, I can see Salma nipped her hand up, so I'll pause for a second to ask Salma to come on camera and ask a question before I invite Councillor Khan. So Salma, are you with us?
Yes, I am. Thank you so much, Justin. I know we're time limited, but I was wondering in terms of our role in next steps from healthcare and social care perspective, with the wonderful work that you've been leading on with Blake Cheer, we're looking at how do we look at the statistics, but then how do we have a practical series of recommendations and hold ourselves to account. So I was wondering whether that kind of model, without saying we can do everything at once, especially where we see the kind of scale within certain communities, how can we take that approach and start to operationalize this so that we're not here in the next 3, 4, 5 years saying, here's some more stats, but they don't look that much different from the ones that we presented 5 years ago. So I just think there's an opportunity to tie in at least that approach. So we'd have to kind of do it almost separately for each community, whilst bearing in mind that it's person-centred, but operationalise this stuff. And the second question is just, who are the commissioning partners that you're thinking of in terms of next steps from your perspective?
Yeah, so I'll just pick those up quickly and I'll also pick up Atif's question in the chat about the research samples. So I think it was probably something, Salma, you and I offline have a chat about. But I think one of the things is we've gone through the profiles and we've also heard from communities how powerful this is to go deeper, how much it's valued for us to really see and bring to light and be visibly discussing the Muslim community separately from the Hindu community, separately from the Sikh community, and that matters. we've got to then talk, I think, as a partnership across the city about how we respond, because we can't do everything everywhere all the time, on all of these communities. And there's got to be a bit of sharing out of who's going to take the lead on this one for the public sector versus who takes the lead for our bisexual community in terms of the public sector. So I think we've got to do a bit of mapping, both with the NHS, but also with the wider city partnership, and perhaps ask organisations to take leadership on one profile over the next 2 years and work with us on that. In terms of the commission partner, as Hannah's put in the chat, I'm grateful because I wasn't sure whether we'd locked down the final stage yet. The Bahu Trust have been commissioned. We went to open market tender, as we do routinely for these, and the Bahu Trust will be taking forward this profile and the Muslim faith setting profile as well. So there was an open commission, and it was up to people to apply for it. But so if you do know local groups, local organisations that be interested, please connect them with the Bahu Trust. On the Somali point that Nemo puts in the chat, there is a separate community profile on the Somali community, and we are currently out to market for a partner to engage with the Somali community. So please do encourage people, if you work with the Somali community, you're interested, please look on Find It in Birmingham. On the point around the research samples, we are working with the universities, and one of the other audiences, along with Alex's point about the businesses, is we need to play these into the 9 universities of the city and say, look, what we're consistently finding is the evidence base is not good enough. You work with us on that. And the same is true, I think, with the commissioners, and particularly around commissioners' responsibilities to make sure that services are capturing data. And I think that's across the breadth of the public sector, because if we're not asking people when they come in the front door who they are, we're not going to give them the best service, but we're also not going to be able to see who's not coming through the front door and be able to respond and recognise that. So I hope that's picked up some of the points that have been raised. I am conscious we're coming to the end of the session, so I'll invite Councillor Khan just to say a few words of closing for us. So thank you.
Thank you, Justin. And yeah, in my closing remarks, I'd just like to say, firstly, thank you for everyone who stayed all the way through and has taken part in the Mentimeter aspect and just given your thoughts as well. I think overall, I've done a few of these now, and this one, and as I said earlier, as a Brummy Muslim, I think some of the stats and some of the information that we already knew, but without having the data to back it, really sort of hit home. There were quite a few slides for me that I thought, oh my God, this is really interesting. And I know that we've got I've got the slide already circulated, but I found myself pulling my phone out and taking quick pictures of some of the slides just so that I've got access to them, so I can start pulling those facts and those details and data out when I'm having conversations with people. I think one of the key things in the question that I found, that I thought of in terms of what can you do personally in your organisation, I thought rather than me talking about all the things I can do as a cabinet member and typing frantically in the Mentimeter, I'll just say, I think coming to sort of having been to quite a few of these launch events, it's critical for me that the message needs to be passed down to the rest of the elected members. So for me, I've seen that I personally find these really interesting, and it makes sense for me to feel like that. But I think that I will make it my sort of goal and responsibility to ensure that this message is passed down to other elected members of the council, in order for them to understand that they can then take these to their local groups. For example, the stats and details around sports. There are sports organisations and there's community groups locally within our local wards and communities and areas that would find that really useful information to be able to encourage and engage more participation. Because when you give the detail to people from that particular community, you're more likely to feel engaged to try to better those stats and those details and data. I completely agree with you, Justin, about further steps and that ownership. I think it would be public health would never be able to keep on top of all of the community health profiles, because you've managed to produce so many of them in such a short space of time. So it's really key to match them up with the right external partner organisation so that they can keep track of each individual one. I think that's the right approach to take. And I would just ask, in terms of when the census data is available, I know that we're due to sort of do a proper refresh of them, you know, after a number of years. But I was just wondering whether we'd be able to do, whether we're planning on doing a sort of a refresh once census data is made available across the community health profiles, and then wait for the regular sort of 5-year rounds to properly update them. So that's just another question back at you, Justin. But final remarks, you know, really pleased to be able to launch these health profiles, and I'm sure that people who've been on this call will appreciate how much work has gone into creating them, and also see how valuable they already are. But moving forward, there's obviously lots of other work that can be done to update them, and further information as more data is made available on more specific things in terms of, you know, for example, the Muslim health profile. All Muslims aren't exactly the same, and their lifestyles are not all exactly the same either. So thank you once again, and I'll hand back over to you, Justin.
Thank you very much, Councillor Khan, and I'll pick up with you offline the census plans, but the aim is what we will aim to do is produce a kind of supplementary annex document, which will probably just be half a side that says this is what the census data has, that sits alongside each profile, primarily because if we have to go back in and re-edit it, that's quite a fun bit of design work. But that is the plan. As I put in the chat, the Office for National Statistics control the census releases. We know that it's running significantly behind what was planned because of the work they've had to do on COVID. So that we were expecting some things like faith and religion to be out by now. That's likely to be the end of this year, beginning of next year, and then the more detailed stuff will come after. So the census results are released over about a 5-year period after the census happens, and so just to manage people's expectations. But my hope is that probably late spring the profiles will have updated annexes with where we have census data that's relevant across the profiles. Thank you again, everyone, for your time today. Thank you for your participation in the Mentimeter. It's been brilliant to have so many on the call. It's also been brilliant to see the chat commitments to disseminating this, to taking it back to your organisations, to your partners, and making a difference. And do have a look at not just this profile, but the other ones as well, because the more that we can work with each other, for each other across communities, the better impact we have for Birmingham. So have a great day and really enjoy the rest of your week. Thank you very much, everyone.